Greetings, dear learners. In the last class, we started learning metallic poisons. In that, we were learning arsenic poisons. Up till now, we are aware with different types of arsenic compounds, their uses in different forms. We also know the mechanism of action of arsenic on the body, its toxicokinetics, fatal dose, fatal period, features of the acute toxicity of the arsenic poisoning, and how to make its diagnosis. We also knew how to differentiate between cholera poisoning and the arsenic diarrhea. Now, coming to the features of the subacute and chronic arsenic poisoning. It is important for the physicians to remember that in the days or weeks following an acute exposure, prolonged or additional signs and symptoms in the nervous, gastrointestinal, hematologic, dermatologic, pulmonary, and the cardiovascular system can occur. Encephalopathic symptoms of headache, confusion, decreased memory, personality change, irritability, hallucinations, delirium, and seizure may develop and persist. Peripheral neuropathy typically develops 1 to 3 weeks after the acute poisoning. Sensory symptoms develop first and diminish to absent vibratory sense may be present. Then progressive signs and symptoms include numbness, tingling, and formication, that is sensation of the walking of the ants or insect on the body, with physical findings of diminished to absent pain, touch, temperature, and the deep tender reflexes in a stocking globe distribution. Superficial touch of the extremities may elicit severe or deep aching pains, a finding that also occur with the thallium poisoning. Superficial touch of extremities may elicit severe deep aching pains, a finding that also occur with the thallium poisoning. Motor weakness may then develop, and the most severely affected patients may manifest with the ascending flaccid paralysis that mimics the Guillain-Barré syndrome. There are reports of delayed encephalopathy and the neurotoxicity from the parenteral administration of the chemotherapeutic arsenic trioxide in patients with the solid organ tumors and acute promyelocytic leukemia. Respiratory problems can include dry cough, rales, hemoptysis, chest pain, and patchy interstitial infiltrates. These findings may be misinterpreted as viral or bronchitic disease, leukopenia, and less commonly anemia and thrombocytopenia occur from days to 3 weeks after an acute exposure but resolve as the bone marrow functions returns. Dermatologic lesions can include patchy alopecia, oral herpetiformic lesions, a diffuse pruritic macular rash, and a browny non-pruritic deesquamation. Diaphoresis and edema of the face and extremities can develop. These lines may be seen. Contact dermatitis has been reported from the topical exposure in an occupational setting. Other possible toxic manifestations of the subacute inorganic arsenic toxicity include nephropathy, fatigue, anorexia with weight loss, torsades pointis, and persistence of gastrointestinal symptoms. And chronic arsenic exposure has been associated with increased incidence of diabetes mellitus, cerebrovascular diseases, and chronic lung diseases including COPD and bronchiectasis. You can see here in the slide that subacute poisoning is called between 24 hours to 4 weeks, and different systemic manifestation that involves cardiovascular, skin, hematologic, CNS symptoms are all involved in case of the subacute poisoning. Then the chronic poisoning, that is beyond 4 weeks. However, the WHO definition says that chronic poisoning of arsenic is defined as chronic health condition arising from prolonged ingestion of not less than 6 months of arsenic above a safe dose, usually manifested by characteristic skin lesions with or without involvement of internal organs. So here the skin lesion is the most important in case of chronic poisoning. That shall be the manifestation with or without involvement of the internal organ to call it a chronic poisoning. The features of the chronic arsenic poisoning can be categorized into the four stages: gastrointestinal, dermatological, neurological, and neuromuscular. In the gastrointestinal phase, that is the earliest to appear, it occurs within weeks and months of the initial exposure. General symptoms presented by the patients are edema around the eyes and the ankles, weight loss, malaise, tachycardia, low grade fever. Then gastrointestinal symptoms are loss of appetite, metallic taste in the mouth, burning sensation in throat, red and inflamed gums, white coated tongue, nausea, vomiting that may contain the blood, abdominal pain, constipation or the diarrhea. Then stage 2 is the dermatological manifestations that develops over the months to years of the exposure. Dermatological manifestations includes the hyperkeratosis, as you can see in the picture. The palms and sole show the multiple discrete hard wart-like growth on the palms and soles, also less commonly on the head and the trunk. This occurs due to epithelial hyperplasia. It may also turn into the malignant cancers like the basal cell carcinoma and the carcinoma in situ, that is the Bowen's disease. Also, arsenic is teratogenic and can result in the lung and skin cancers and the leukemias. Then another dermatological manifestation is pigmentation, that is melanosis. As you can see here in the picture, the color is finely mottled brown, usually on the flexure surface of the skin, eyelids, temples, necks and other areas. It is looking like a raindrop pigmentation. Covered parts of the body are also affected and it may persist for months. Then the rash on the body resembling the measles rash may be present, and the flexural eczema are the dermatological manifestations of the chronic arsenic poisoning. Along with the dermatological manifestations in this stage, certain other features are also seen. That includes the fall in hair and the dry and brittle hair. Nail shows irregular thickening, brittle and meese line on the nails. The meese line you can see here in the picture are the basically the transverse 1 to 2 mm of the white striations in the fingernails, as this was first described by the C.J. Eldridge. So it is also known as Eldridge meese line. It is also seen in subacute arsenic poisoning. Then eye may show congestion, lacrimation, photophobia, diminish of vision. Nose may present with intense inflammation of the mucous membrane lining the nasal cavity, running nose and the perforation of the nasal septum, that is painless. The feeling of dryness and itching in the throat may be the presentation. Voice is hoarse and dusky. Larynx and bronchi may be showing inflammation, that is spasmodic in nature with bloody expectoration and cough. Dyspnea may be the findings. Then patient may present with the liver cirrhosis, hepatomegaly, jaundice. In the cardiorenal system, myocarditis, cardiac failure, chronic nephritis and dependent edema may be seen. Then stage 3 is the neurological stage that develops from the months to years after the stage 2 and progresses with continued exposure. General signs and symptoms are the worsening of the edema. In the neurological manifestation, the anesthesia, hyperesthesia and the paresthesia sensation are there. Encephalopathy, polyneuritis, that is glove and stocking type of polyneuritis that presents with the headache, numbness and tingling sensation. Knee jerk is lost in the patient. Muscles may be markedly tender and the cramps may be present. Then arthralgia, hematological manifestation may present with the anemia due to bone marrow suppression and that causes aplastic anemia, and hemolysis may be seen. The nature of the anemia is normocytic normochromic anemia. Bone marrow examination shows bizarre nuclear forms and karyorrhexis. Leukemia, thrombocytopenia may be other features in the blood film. Then impotence may be the presentation of the patients. And then the last stage is the neuromuscular stage that represents advanced and often irreversible damage. There is the severe muscle atrophy, paralysis, respiratory difficulties due to affected intercostal muscles. The patient presents with a difficulty in passing urine, that is dysuria, and mental disturbances that includes the different types of delusions. Then the cause of death in such patients is usually the heart failure or sometimes the respiratory failures. In this way, the manifestations of the chronic poisoning of the arsenic are seen in the patients. I already discussed in the last class the presentation in the patients of the West Bengal region with the chronically exposed high level of the arsenic in contaminated drinking water. The patients were presenting with the raindrop skin pigmentation in 100% of cases, palm and sole keratosis in 65% of cases, weakness in 70% of cases, gastrointestinal system, respiratory system involvement, nervous system involvement, abnormal electromyography, abnormal nerve conduction abnormality, then hepatomegaly, splenomegaly, abnormal liver functions, portal hypertension. These all features we came to know in the percent presenting in the that West Bengal region. Then to better differentiate between the acute and chronic arsenic poisoning, we may refer to this table. Here the dermatological manifestation in acute poisoning is hair loss, the transverse band of opacity in the nails, that is Mees line, seen basically in the subacute poisoning and the chronic arsenic poisoning. Then the melanosis in neck, eyelids, nipples, Bowen's disease, that is the cancerous outgrowth of the raindrop pigmentation, facial edema, hyperkeratosis, hyperpigmentation, and the skin cancer are the chronic manifestation in arsenic poisoning. Then in the ocular changes, conjunctivitis and lacrimation are seen in the acute exposure. On chronic exposure, there is dimness of vision. In the gastrointestinal system, acute poisoning presents with abdominal pain, metallic taste, dysphagia, vomiting, bloody or the rice water diarrhea, garlic odor in breath. Whereas in chronic arsenic poisoning, there is anorexia, nausea, vomiting, diarrhea and the weight loss. Airways, acute presentation will be irritation in the upper airways. Chronically, the patient will present with perforation of the nasal septum, chronic laryngitis, bronchitis. Liver will have fatty degeneration in the initial phase, then later on the hepatomegaly, jaundice and cirrhosis. Renal manifestation will include oliguria and uremia in acute stage, whereas renal damage in the chronic stages. Neurological manifestation presents as hyperpyrexia, convulsions and coma in acute condition, whereas chronic condition present with encephalopathy, polyneuritis, tremor, ataxia, limb tenderness, difficulty in walking. Hematological manifestation in acute period is usually negligible. Then the chronic hematological manifestations include anemia, leukopenia, thrombocytopenia, basophilic stippling, karyoraxis, pancytopenia. Cardiac manifestations in acute phase includes the tachycardia, hypotension, cardiac arrhythmias, whereas chronically the patient is hypertensive and the myocarditis may be the findings. Then coming to the treatment of the arsenic poisoning. In general, the ABCDE of the resuscitative measures shall be taken if the acute toxicity is presented. Then the different measures shall be taken. We already talked the different types of chelating agents that are helpful in case of different metallic poisons that are very beneficial and are the actual antidote against the metallic poisons. Briefly, the gastric lavage with warm water and milk for the arsenic removal may be applied. Whole bowel irrigation for radio-opaque material visualization may be done. Whole bowel irrigation may be done if it is seen on the X-ray of the abdomen. Then BAL and its analog may be given. Arsenic acid conjugated to the ova-albumin for active and passive immunization may be given. Butter and greasy substance to reduce its absorption. Continued nasogastric suction is essential for arsenic resecretion in the gastric tract, especially when taken parenteral route. Then D-penicillamine may be used along with the BAL, that becomes more effective. Then in detail, the management of arsenic poisoning may be done in the following headings: supportive measures, chelation therapy, hemodialysis and hemodiafiltration. Supportive measures like gastric lavage is done in the acute poisoning. Intravenous fluids, cardiac monitoring, and the symptomatic management shall be done. Where the practical expertise exists, consider gastric aspiration or lavage in adults within 1 hour of potentially life-threatening ingestion of an arsenic compounds, providing the airways can be protected. Activated charcoal is unlikely to be of much benefits. Commence intravenous fluids in patients with diarrhea and vomiting. Correct electrolyte disturbance and consider need for blood transfusion if hemorrhagic gastroenteritis is present. Careful attention to fluid balance is important because cerebral and pulmonary edema may be present. Drugs that prolong QT interval such as the class 1A, class 1C and class 3 antiarrhythmics should be avoided. Potassium, magnesium and calcium concentration should be maintained within the normal range to avoid exacerbating a prolonged QT interval. Consider magnesium sulfate when the QT heart rate normogram indicates a risk of torsade de pointes, especially if other risk factors are present. Note that while magnesium sulfate may terminate torsade de pointes, it does not shorten the QT interval. Magnesium sulfate is administered IV over the 10 to 15 minutes in an adult in a dose of 2 grams and a children in a dose of 25 to 50 milligram per kg. Torsade de pointes and ventricular tachycardia or fibrillation preceded by prolonged QT interval should be treated urgently with the magnesium sulfate. Administer IV magnesium sulfate over 30 to 120 seconds in a dose of 2 grams in adults and 25 to 50 milligram per kg in children. This may be repeated twice at an interval of 5 to 15 minutes if necessary. Torsade de pointes may respond to increasing the underlying heart rate through the atrial or ventricular pacing or by isoprenaline infusion to achieve an initial heart rate of 90 to 110 beats per minute. Magnesium concentrations should be measured after the administration. Glucose concentrations and glycogen stores should be maintained parenterally with dextrose and hyperalimentation solutions or with enteral feeding in view of their beneficial effects in experimental model of the arsenic poisoning. If radio-opaque material is visualized in the gastrointestinal tract, then whole bowel irrigation can be administered until the radio-opaque material is no longer seen on the repeated abdominal radiograph. Continuing nasogastric suction may be important in removing the arsenic resecreted in the gastric or biliary tract. In case of chronic toxicity, patients should be removed from arsenic source and gastric decontamination should be performed. If there is evidence of arsenic in the gastrointestinal tract, arsenic can be readily removed from the skin with soap, water and the vigorous scrubbing. In all cases, when the homicidal intent is suspected, patients should be advised against accepting any sort of foods or drink from anyone who might be responsible. Also, hospital visitors should be closely monitored and outside food products should be forbidden. These all things include in the supportive measures. Then chelation therapy, this can be done with the British anti-leucite or the dimercaprol, penicillamine, DMSA, DMPS. The usual agent employed is the BAL at a dose of 3 to 5 milligram per kg intramuscularly every 4 to 6 hourly until the urinary arsenic excretion dips below 50 micrograms per 24 hours. Its therapeutic to toxic ratio is narrow, with adverse effect likely to occur in patients receiving doses of 4 mg per kg or greater. As we already discussed, British anti-leucite is administered intramuscularly in peanut oil. The injections are painful and can lead to sterile skin abscesses. Usual duration of therapy is 7 to 10 days. In patients who are not allergic to penicillin, D-penicillamine can be given orally at a dose of 100 mg per kg, 6 hourly for 5 days. DMPS and DMSA are said to be superior to the BAL and the penicillamine. However, they are not available currently in the India. They contain the vicinal diethyl moieties that bind arsenic to form a stable 1 to 5 arse dithiones and are most effective when administered in doses equimolar to the arsenic burden. There are sufficient data to determine which chelating agent is the agent of choice, but limited evidence favors DMPS, which has now been used successfully in a number of cases of arsenic poisoning. Both agents are available in the Western countries on the named patients basis. DMPS is marketed as parenteral and oral formulation, whereas DMSA is only available orally. DMPS given intravenously in a dose of 30 mg per kg per day for 5 days, which may be repeated if necessary after 5 to 7 days. Orally, if the intravenous formulation is not available, consider oral DMPS. Since the viability of the oral DMPS is only 39%, oral DMPS would need to be administered in a dose of 77 mg per kg per day for the 5 days to achieve the same serum concentration as DMPS 30 mg per kg per day intravenously. A further treatment course may be given after 5 to 7 days. Treatment in 5-day course should continue until there is relief of systemic clinical features. If possible, monitor the patient's blood and urine arsenic concentration during and following chelation therapy to determine whether a further course of chelation is necessary. DMSA in the dose of 30 mg per kg per day can be given in 3 divided dose orally for 5 days and repeated after 5 to 7 days if necessary. The decision to initiate the chelation therapy should depend on the clinical condition of the patient as well as the laboratory result of the arsenic in urine, hair and the nail. A severely ill patient with a known or suspected acute arsenic poisoning should be chelated immediately prior to the laboratory confirmation. Repeat courses of chelation therapy should be prescribed in severe poisoning until the 24-hour urine arsenic level falls below the 50 microgram per liter. Observation for return of symptoms is strongly recommended. Cases of subacute and the chronic toxicity can await the laboratory confirmation prior to beginning the chelation unless the clinical condition deteriorates. Chelation therapy is not very effective for chronic poisoning and is totally ineffective. The arsine poisoning should be treated with emphasis on respiratory stabilization and the hemodialysis. Then for the hemodialysis and the hemofiltration, it may be required for the clinical management of the patients with established renal failure. Although hemodialysis has been used in number of cases of acute arsenic poisoning, the amount of arsenic removed in the disalate was small because this was consistent with the rapid clearance of arsenic from blood to the tissues. So this is all about the treatment of the arsenic poisoning.